As Claire mentioned, if people could put their sort of name and position and interest in the chat box, that'd be really useful, please. And it's really good to see so many different health professionals joining us today. I think we'll make a start. Thank you all very much for joining us today from all aspects of healthcare. It's so lovely to see physicians associates and nurses, GPs, and a variety of other health professionals joining us. It's wonderful because you're all actually helping to manage patients. And nowadays, with this new way of consulting and having various health professionals consulting, it's fantastic because you will all be managing patients who present with gynecological problems. So just a bit of housekeeping, please. If you could put your details in the chat box, that'd be really useful. Please put yourself on mute. We nearly heard a fire alarm going, I think, and hope everyone's safe there. But please put yourself on mute. If you have a question, please put it in the chat box. Or raise your hand if it needs to be absolutely important and essential you ask that question. We will try and make it as interactive as possible. I know that Professor Sean Kehoe is quite happy to accept questions occasionally, but we will be monitoring the chat box and try and answer some of your questions as best as we can. I'm really delighted actually to have Professor Sean Kehoe has joined us today from Oxford. So thank you, Sean. He's going to be talking us through various cancers, the issues therein, talk about a variety of presentations as well as considerations, how to make a quality referral. I'm sure we've all faced occasional downgrading or rejection of referrals, so he might even explain some of that as well to us during the course of some of the cancers. We want to end with any questions people have, but also we require a survey to be completed by yourselves because we want to make sure that we're, as an alliance, we are actually delivering the right information to you that would actually make you feel a lot more confident in managing conditions. And we'll give you some resources at the end. Next slide, please. So this is the agenda, but it's going to be fairly sort of fluid there's only one gentleman who's going to be presenting, and his name is Professor Sean Kehoe. Over to you, Sean.
Thank you very much indeed, and good afternoon, everyone, and thank you for joining this meeting. As you can see it there in the agenda, essentially, I will go through the 2-week rate referral plans that are in place by NICE, and also give some information en route as to what's happening in some of these cancers and some information on them. So I hope you will find it fruitful. I'll start off by showing you, first of all, as we are focusing, excuse me, on 2-week waits, to let you know what's actually happening out there. And you can see here that the 2-week rate referrals in the last 10 years have doubled. The impact of that is raising the amount of patients from 41% to 52% who have cancer diagnosed via that pathway. So we hit about 50%. I don't think we'll ever hit 100% for sure, but it does show you the volume and numbers of patients that you have to put through to keep increasing the patients with cancer coming through 2-week waits. So that's a lot of work that's been increasing, and I'll show you the figures now with regards to Oxford and its referrals, and I suspect that this is probably happening right around the country. But as you can see, we're looking at, in the blue down this end, patients in 2019 who were referred, and on the yellow here, we see what's happening last year. So quite a jump in the number of referrals. And looking at this year, this is the yellow here we are now. So we've moved somewhere from about 40 patients being referred a week in 2019 to nearly double that in 4 years. And that, understandably, means a lot of resources need to be put into this part of the service to try and get to see all the patients within the 2-week wait. So it's quite a lot of pressure on the system around the country. I'm just briefly going to go through the referral guidance from NICE with respect to each of the cancers, starting with ovarian cancer. And we can see here the symptoms, particularly they've been there for more than 12 times per month, of persistent abdominal distension, feeling full or loss of appetite, pelvic or abdominal pain, and increased urinary urgency and or frequency. Of course, a lot of these symptoms may be related to other conditions rather than ovarian cancer, but these are felt to be the signals that one looks for if a patient does present to you with these type of symptoms. Unexplained weight loss, fatigue, or change in bowel habit, again, they can be related to many other conditions. And primarily with these symptoms, we undertake a CA125 in primary care. And then if the CA125 is elevated, an ultrasound scan of the abdomen and pelvis, particularly of the pelvis anyway, is required. It's at that point in time that the patient should be referred. So the emphasis I want to put here is that, and I'll come to in a second as well, is an elevated CA125 alone is not the complete referral, if you like. There should be an ultrasound where an abnormality in the ovaries is found. And that's one of the areas that we do have difficulties with patients just being referred for CA125 and then having to arrange the ultrasound, etc. So I would make a plea on that. As I say, raised CA125 does not mean ovarian cancer. Particularly in premenopausal women, you have multiple conditions that can cause an elevated CA125. These are just a few here of pregnancy, endometriosis. If the sample is taken while the woman is menstruating, that will raise the CA125. Infections of all sorts can raise it. Post-surgery, somebody's had surgery, the CA125 can be raised for up to 3 months. And fibroids. And should point out as well, you will get a proportion of women who will have a persistently raised CA125. In other words, they're just the outliers, I suppose, that are found on these tests. But when a CA125 is raised and there is no ovarian pathology, you then have to consider other reasons or other investigations. I was actually on a committee for early diagnosis of ovarian cancer in the Department of Health. And these issues here are actually brought up by a team of general practitioners stating that other areas should be considered, i.e. that may entail a CT to see if there's any other disease present. So my request here is please do not refer patients just because of an elevated CA125. Equally, I should point out that there's no screening, as many of you I hope know, for asymptomatic patients. It's not part of the NHS or indeed the US guidance either. There is no effective screening method. 2 studies were undertaken, the first in the US, where they found no benefit to screening the general population, and this was for women over the age of 50. And the largest study in the world was done here in the UK, and again, unfortunately, found no benefit. And the reason for that is that when these screening programs were being undertaken, the focus was looking for ovarian pathology. We now know that for high-grade serous carcinomas, and I'd say the same for peritoneal carcinomas as well, that the reality is that the vast majority of these arise in the fallopian tube. Therefore, if you're screening the ovary, in many cases, you're screening metastatic disease. And it's probably why these screening trials did not show any benefit. But that wasn't known at the time. That's only been known in the last 10 years. And we do see a situation where in many papers and people talking about ovarian cancer rates falling, and working with colleagues at the NCRAS, we did have a look to see what was actually happening with regard to this some years ago. And we found was, of course, there was an increasing diagnosis of primary peritoneal or fallopian tube cancers being made, and they were being registered in a different setting. When you add the fallopian tube, peritoneal cancers, and ovarian cancer rates together, they seem to be remaining pretty static. Uterine cancers, this used to be the second most common gynecological cancer when I started in gynaecology. Now it's the most common gynecological cancer. And it's estimated that approximately 50% of endometrial cancers are attributable to obesity. And of course, as we know, in the UK, we do have very high rates of obesity. And that goes in tandem with the rises in endometrial cancer, which have approximately doubled over the last 10, 20 years. As you can see, when looking at obesity and its relationship with cancers, the most consistent rise relates to endometrial cancer, where patients with overweight, they'll have 2 to 4 times more likely to develop this cancer, and 7 times with severe obesity with a BMI of 40 or more. In clinical practice, it is not unusual for us to encounter patients with BMIs of 35, 40 and above. It's now become quite common. And the second most common one that occurs in this study from the NCI reveals esophageal cancer is increased significantly with obesity. And we can see here the figures from the UK, 50% increase in endometrial cancer, or 70% increase in recent years of endometrial cancer, and increases in weight. The impact this has, of course, is that probably less than 10% of women who are referred with postmenopausal bleeding will actually have cancer detected. So you can see that you're going to have to, if you like, screen 100 women with postmenopausal bleeding to pick up probably 9 to 10 patients who do have cancer. And if you kind of extrapolate that further, you can see that the numbers end up in the tens of thousands, particularly with the increase in rates of endometrial cancer. The guidance from NICE, and this is in use presently, is to refer women using a suspected cancer pathway for endometrial cancer if they are aged 55 years and over with postmenopausal bleeding. That's unexplained vaginal bleeding more than 12 months after menstruation has stopped because of the menopause. You can consider a suspected cancer pathway in women under the age of 55 with postmenopausal bleeding, and consider direct access ultrasound scan to assess for endometrial cancer in women aged 55 years and over. They have unexplained symptoms of a discharge, presenting with these symptoms for the first time, or have thrombocytosis or reported hematuria or visible hematuria, low hemoglobin, thrombocytosis, or high blood glucose levels. And I think it's important to point out here, they're saying consider, not saying it's mandatory. A lot of the work done here is based on analysis from the Exeter GP practices, where they looked at patients who had endometrial cancer, comparing them to those who didn't, and they found that thrombocytosis was present. Thrombocytosis, I have to state, is not uncommon in cancer, but the consideration is there due to the fact that it is not a very, very strong marker that somebody has endometrial cancer. Another issue I thought might be helpful was the issue surrounding HRT. It's quite important to realize that unscheduled vaginal bleeding is a common adverse effect of HRT within the first 3 months of treatment. Therefore, During that period of time, there is no need to refer somebody with some irregular bleeding just because they've started HRT. There may be issues surrounding the type of HRT. It's quite possible it needs to be changed, but it shouldn't automatically result in an immediate referral. A continuous combined HRT commonly produces irregular breakthrough bleeding or spotting in the first 4 to 6 months of treatment. If the bleeding persists beyond 6 months, it becomes heavier, or occurs after a spell of amenorrhea, endometrial pathology should be excluded. So it's quite important to take that into consideration for women who are on HRT. And also of note, endometrial thickness 7 to 8 millimeters is common in women who are taking HRT. So the main message here is immediate referral because of bleeding for somebody who started HRT recently is not necessary. Cervical cancer, this is the recommendation for referral of a person or a woman with suspected cervical cancer. As you can see, consider a suspected cancer pathway appointment within 2 weeks if on examination the appearance of the cervix is consistent with cervical cancer. This is really just to point out that colposcopy is not the appropriate place for such patients. They should come through a 2-week wait cancer pathway. And also the history of postcoital bleeding, for your information, the rates of cancer in women with postcoital bleeding is about 1.7%. However, having said that, I must admit that in many cases, postcoital bleeding is associated from experience with cervical cancer. It's just nowadays, the early cervical cancer we do often pick up because of an abnormal smear. You should also be aware of the fact for adenocarcinomas, which are usually in the endocervix, you can still have the appearance of a normal cervix, but on palpation, you may well actually feel the cancer being present. They, though, constitute only about 20% of all cervical cancers. Equally, by the way, even though the methods used now for cervical screening are excellent, adenocarcinomas is the type of cancer where you can actually get a normal smear. Screening was always focused on cervical squamous carcinomas and not, if you like, built to detect the adenocarcinomas. But with the HPV testing, the pickup rate now is higher than previously. And this is the screening system now for cervical cancer. It is using HPV detection as part of it, with liquid-based cytology, and then referral, where appropriate, for colposcopic assessment. Those with high-grade lesions presently should be seen within 2 weeks. One of the issues surrounding screening is the fact that the pickup for women attending has been decreasing. And that does pose somewhat of a problem because you are looking to try and screen 80% of your target population, as I said, in order for the screening program to be cost effective. So encouraging women to attend and have their smears taken is important. However, on the other side, I think of all of the cancers that I have encountered, cervical cancer is one where there's a very positive outcome over recent years. And this is due partly to screening, but also improved therapies, particularly non-surgical therapies in the management of cervical cancer. And we have the HPV vaccination program, which is up and running and is being taken up at very high rates initially and still remains at very high rates. And it is anticipated that in the future, that women who have had their vaccination, that the screening might be reduced somewhere around 2 to 3 times screened in their lifetime. That, of course, would be of tremendous value and would ease the pressure on the screening program as well. To date, the evidence is accumulating, showing a reduction in cervical cancer with the vaccination program. It is relatively early days, but everything is pointing towards a significant fall in the incidence of cervical cancer in those who have been vaccinated. It was estimated probably would reduce cervical cancer by about 70%, but with the herd immunity that's been recognized now, is probably going to be higher than that. And as the years go on, the amount of high-risk HPV types that can be targeted has risen from originally 2 types up to now 9 types. So overall, we should see the beginning of the elimination, in effect, of cervical cancer, at least in the high-income countries. The real challenge in the world is targeting the low and middle income countries, trying to get vaccination programs there, as in those countries, cervical cancer now exceeds maternal mortality as a cause of death in women. And that itself is another presentation on its own. So, good referral practice. If we think there is a possibility of ovarian cancer, a CA125 with the pelvic scan is the ideal. In endometrial carcinoma, again, the scan is pivotal, as the endometrial thickness will determine the requirement for further investigations. For cervical cancer, and indeed vulval cancer, that is very much dependent on the clinical findings of the patient. And also ensure the patient is aware of why the referral is being done, i.e., there is a concern of a possible cancer. I do some of the 2-week wait clinics occasionally, assisting our colleagues, and I just thought I would highlight some of the referrals that I came across. Now, this is not to point fingers at people or anything like that. That's not the aim of this. I appreciate everyone is under tremendous pressure in trying to manage large patient populations without the workforce requirements to deal with that. You do see patients being referred with a slight concern. So they're not very concerned that it might be a cancer, but do want the patient seen, and that's quite understandable. And I just want to highlight, at least in Oxford, I can't speak for the other trusts in the region, but if a patient is referred urgently to gynecology, there will be a slot made for that patient to be seen within 4 to 6 weeks. I've had patients referred quite aware that they did not have a cancer, but were told this is the quickest way to be seen. And again, it's just to emphasize, if you need a patient to be seen in gynecology, you can get that 4 to 6 week slot by requesting that the patient be seen urgently. I had a patient referred because they needed follow-up. They had a long history of many years for a pre-invasive condition of the vulva and just had moved to the area. The patient was referred, and I asked about the lump because that had been ticked on the 2-week wait referral, and the patient was not aware of a lump whatsoever. I've had patients also who've actually told me that they were told not to be concerned, that it'll say cancer on the letterhead. You don't have cancer, but I'm still going to refer you by the 2-week wait. And another lady who had a Bartholin cyst for 2 years becomes a 2-week wait, when again, the patient could have been referred urgently. I know this is not happening all the time. There are obviously good pickup rates from the 2-week referrals. It's just pointing out that the strain on the system, we should make every effort to try and utilize it as efficiently as possible. So it's just a plea for that to be done. So in conclusion, just going through that, and I'm happy to answer as many questions as possible. Probably the more interesting part is, but importantly, it's important to adhere to the NICE guidance. Otherwise, the system is going to get completely overwhelmed. And indeed, I would say it is overwhelmed presently. There is an urgent pathway where the patients for gynecology can be accessed and seen within 4 to 6 weeks. I'm quite sure the figures that I'm showing you here is pretty much what's occurring in other trusts. We did do that with colleagues, asked colleagues to do audits of where the delays were in getting patients through a 2-week wait system. And there were very, very similar problems around accessing ultrasound, histopathology, being delayed for a variety of reasons. And we do recognize that this is the early stage of the pathway is a problem presently, and therefore trying to tighten up and get appropriate referrals through the system will speed up that earlier path of the pathway. And again, that's a plea for your help in that as much as you can. So I thank you, and I will go over, answer any questions that I can. They're in the chat box, I assume, but thank you very much for your attention.
Sean, thank you so much. That was a very clear, succinct sort of précis of cancers in women, which is brilliant, absolutely superb, and really, really good some points made there, especially the case histories that you highlighted from 2-week wait. Now, the audience is very quiet, actually. I'm surprised because, you know, Thames Valley has a very interactive audience ready for it, but I think maybe it's the workload in primary care that's grinding everyone down. But I think a couple of questions, and I think I probably started some of this conversation, was access to ultrasounds. You know, with an abnormal CA1 to 5, access to ultrasound seems to be a bit of a problem. Some areas seem to have access to ultrasound and may have urgent pathways, but I gather from one of the delegates who attended today, Twyford, Jennifer Hay, you're saying that we don't have access to community ultrasound access anymore. And there are some rejections from radiology when you say an ultrasound is required. So, and pressure then to actually pass them through to the Gynae 2-week wait. Sean, how would you respond to ultrasound requests?
Yes, I think that's a very valid point. I believe you should have access actually to ultrasounds, particularly as a patient, say, with elevated CA125, and they should actually do the ultrasound as a matter of urgency. It must be very frustrating having that, and I do appreciate the fact that that may well be the case for referring the patient just with the CA125. Um, it's probably just as with regards to community ultrasound, I don't have a real feel on that, but I can see where that could be hugely beneficial. Yes.
It's can I sorry, hi guys, it's Sean, it's Sarah Phillip here. I'm the I know gynae consultants at Reading. Community access to community ultrasound is a real challenge. So we lost I think there was a contract that was lost for community-based ultrasound around COVID or just before COVID. It was outsourced, and then that work has been taken back on by the Royal Berks. So the open access ultrasound comes into our main radiology department. They are absolutely swamped and overwhelmed with requests, and they haven't got the machines, the rooms, the sonographers, the time to be able to deal with all of the requests, which is why we had to make a pragmatic decision about the 2-week wait referrals coming out of the GP open access, because they just wouldn't get done in time. Their wait times are huge, and that's why they've had to tighten up on their criteria for scans, which is why our colleagues out there in primary care are facing rejection. So this is a real challenge, because we're facing the increased referrals coming into our service for scans and everything else. The GPs are finding it really challenging out there with patients, but we have an issue with access to ultrasound, and that's going to need some resourcing and probably some conversations with those who may be able to help us with that. But yeah, that's where we are in Reading. I'd be interested to know what pathways and models are in place elsewhere in the region, and whether there may be something we need to do to ensure access is equitable around the region. But that's the situation in Reading.
Thank you very much for that. Anne, over to you. Anne Deans.
Well, what we have done in FHFT is that we've actually employed a sonographer who we triage all our 2-week referrals. So if we get a GP referring in bleeding on HRT, or somebody, and it just needs an ultrasound scan for endometrial thickness, that person sees our sonographer and is discharged back to the GP with the report. That's how we've had to manage this lack of access to urgent scanning. So they don't actually go through a doctor. If obviously they will be, they will see one of our consultants if the endometrial thickness is 14 millimeter and cystic. But if it's a normal endometrial thickness, they go back to the GP without seeing a doctor, if the referral has obviously come through for screening for endometrial cancer. So we've just had funding for a sonographer 5 days a week in our 2-week rural clinic. And we have a system that they can be scanned. And if they need to have a hysteroscopy, we've kept a couple of spaces in our hysteroscopy clinic so that out of the 12 patients the sonographer scanning that morning, she could pass 2 through to outpatient hysteroscopy on that day if necessary, or to see a consultant to take things further.
Yeah, thank you for that. That's really helpful. I mean, it sounds to me as if in order to try and help the volume of referrals, we need to have the correct pathways of diagnostics available to primary care. And because we don't have that in certain areas, the number of referrals are increasing. Or have I got it wrong completely? Because, in order for GPs to assess the patient with an abnormal CA125, appropriately and make a quality assessment, an ultrasound should be available. So have I missed the point, or am I saying the right things, Sean?
Yes, that's exactly, I think, the point that's been made is if the GPs can get access, they will be able to do the CA125, they will get the report back. It says normal ovaries. They'll know then, okay, I might have to just repeat this CA125, see what's happening, and I may have to then refer in, get a CT scan done or whatever. But we're now looking for something that's not related to the ovaries, so we can guide them somewhere. We had huge discussions, I remember this is going back many years, about that, because it's felt very difficult, if you do have an elevated CA125, which might be related to something else, what does the GP do? And I will have to throw this one back because the decision was made by a group of GPs that have to sort that out themselves, which I kind of thought, not sure that's the full answer. But all it does is it means, right, that's not for a gynecological referral. I need to start referring somewhere else in consideration of other reasons for this CA125 to be elevated. But I can see the frustration of being a GP, trying to manage dozens and dozens of patients a day and having an abnormal CA125 and I've no access to scan, which, and understandably, they're going to refer in. So what happens then is the patient comes to us at day 14, quite often nowadays. Then we have 2 weeks for the scan. So we're 28 days, if you like, on the pathway already. We've not really done very much. But as I say, I think it's a collective problem. I'm not blaming anybody, and resources are obviously needed as well to try and get that to work. Very frustrating.
So I think, I think we may need to take this outside of this meeting to see what we need to do, and happy to have pathways that work in areas. So I'm a GP, but I'm also the Thames Valley Cancer Lead, a clinical lead for prevention early diagnosis. So if people want to email me or get in touch, please do. But the other areas that maybe are worth just mentioning is, and please correct me if I'm wrong, the gynecologists on here, you may want to consider referring for advice and guidance. If there are no red flags, or if you just have a concern, advice and guidance might be an option that might just help from the managing workload point of view. And of course, there is the non-site specific pathways in certain areas already available, whereby patients can be referred in as long as the right investigations have been carried out. So one of your slides there, Sean, you said 2-week wait referrals, this is the guidance. Well, we want to try and reduce the pressure on secondary care by making a quality referral, but also making sure we use other avenues like the urgents and the advice and guidance and non-site specific. Sarah, you put your hand up and then you put it down.
It was about advice, and I think it's difficult to give advice and guidance based on symptom, without imaging, isn't it? If you're thinking about raised CA125s, I guess the area that generates the biggest amount of advice and guidance that we receive with women is unscheduled bleeding on HRT, which creates a huge amount of work and potentially clogs up that 2-week wait pathway. Yeah, I know there are lots of good GPs out there who can manage unscheduled bleeding on HRT, but a lot of it does end up coming through to us. Just a comment, really.
No, that's very useful. But I think working collectively and collaboratively, we should manage the patient appropriately, and therefore calling on colleagues through advice and guidance or whatever it is we do in terms of accessing may be a useful way of not only education, but managing patient safety and, of course, helping your workload in secondary care and supporting GPs to know that they're doing the right things. So, yeah, thank you for that, Sarah. HRT, Anne has mentioned that HRT has meant a lot more referrals. Yeah, I mean, I think it is life at the moment, isn't it? And we are learning, aren't we, about when to do that. So, which is why today is really useful. I mean, I think we've had a quote today about ultrasound. I can see lots of comments being made here about ultrasound. So this is something maybe we need to take out of the meeting today to see if the Alliance can help in any way. Any other questions from anywhere at all? One question, please, Sean, and the others. What about transgender people? Are there any things we ought to be considering in transgender individuals?
It's not something that, I mean, I would put it this way, that when it comes to screening for cervical cancer, which is one of the areas, all relevant persons should be screened. But with respect to that, I have to admit that it's not something that's come across anywhere on the radar in NICE or anything that I've seen. Probably a gap in the area there, to be honest with you. I plead my ignorance on that.
And any of the other gynecologists on the call today have any opinions on that or advice? I've struck a chord. What a good question, Sean. Yeah, excellent. I mean, I think one of the key things you mentioned that I sort of heard about today is examine the patient. I mean, I think that's a really, really important thing, isn't it, really? Nowadays with remote consultations in primary care taking quite a chunk of our sort of consultations, I think we must bring patients in. Would you agree with that, Sean?
I think if there's a concern for a cancer, that would be really, really helpful to do that. I do note, in fairness, when I pick out cases that have come across, I have to admit I do see quite a lot where they have actually seen the GP, seen the patient and done the pelvic examination. And that it's really very, very helpful to have that done, because you can pick up other issues such as, cervical polyps, etc., fibroids and various other things, which may explain the problem, and then realizing this patient can actually be referred as an urgent, but not necessarily a 2-week wait. So that is important where it can be done.
Yeah, absolutely. I mean, I think examination is absolutely key, and examination is not just examination; it's also the conversation, isn't it, about why you're referring and what to expect. So I think it's a consultation with examination is, I think, quite an important aspect in primary care. Given the workload pressures, it can still be done because they're trying to exclude cancer in individuals. One quick ignorant question from me. It's not so ignorant, just a clarification. In one of your slides, you say, when you can feel a cervical cancer. Well, I've felt Nabothean follicles, I've seen ectropions. What is the feeling you have when you examine that says this could be cancer?
So we've got a straightforward cancer, if you like, where you're actually going to look and see the cervix. The one, and I wouldn't really criticize, I do get cases, and people talk to me about these cases, and I say, well, actually, it's very, very difficult for somebody to be sure about, is this an endocervical cancer? They're the ones that quietly sit in the endocervix. The cervix itself can look normal, but you can sometimes feel a barrel-shaped cervical tumor. However, I wouldn't be highly critical, because those types of tumors are the tricky ones to pick up. Other ones, like the squamous cell carcinomas, that they're actually visible. But as I stressed, an awful lot of our early stage squamous carcinomas and some of the adenocarcinomas are actually picked up microscopically, because the woman's having a loop done or a treatment for an abnormal smear or high-grade smear. And that's probably one of the factors that's facilitated in the significant reduction in death rate over the last 2 decades in cervical cancer. It's really been tremendous drop in death rates.
Thank you for that. Again, we've got a very quiet audience here. Another quick question from me. Why is BMI really important to be included in a referral in gynecology?
Yeah, there's quite, it's quite useful to know what's coming, if you like, in the sense that the BMI will have some impact on the referral, particularly, again, we'll come back into those patients with the postmenopausal bleeding. There is a stress on the increased weight and its relationship to endometrial cancer. But there are other simple things and practical things, for example, couches and the availability of equipment in order to be able to manage the patients and examine the patients. It just gives a head up to the service as well, besides the clinical implications of it, to ensure that you can care for the patients at first visit.
Thank you. Yeah, and also maybe it's relating to the next step in investigation, isn't it? Is it hysteroscopy or imaging of some sort or whatever?
It could easily influence that patient going and having, you know, a slightly different route because of potentially a very elevated BMI.
Thank you. Thank you. Any questions from anyone or any observations or comments from anyone at all? This is your chance. This is your chance to talk about it. I mean, I think one of the frightening thing that you shared in one of your slides was about screening and the drop in rates. Now, we can blame COVID and the access and workload, but there is no doubt in my mind that screening saves lives. I mean, that's cliche, I understand, obviously, but screening is so important, isn't it, Sean? Cervical screening, I know, is as you said in your slide, HPV is going to have an impact on survival, but cervical screening, picking things up early is really important. And having one of the key things, and this is where PCNs may come in, is having extended access in late evenings and weekends might actually help those people who are well, because screening by definition is for well people. And so maybe PCNs and practices need to see how they can bring people in. So, you know, the screening is really important.
I mean, it's one of the important parts in these reductions that do occur. When you consider if a woman just has one cervical smear, that's normal in her lifetime, she's just reduced her risk of cervical cancer 5-fold. And we're still in the region of, you know, not about 50% of patients coming in will have either not had the screening done appropriately or didn't attend, if you like, to have the smears done. And I think it's just keeping the message going. In future years, we won't be having as much discussions, I suspect, about screening, because if the way the vaccination is impacting on the situation, I think that's going to make a massive change.
Anne has put in the chat about self-swabbing. Now I'm aware of this. Can you explain about self-swabbing a little bit, please?
So essentially, that's the ideal. Is it's what you do is you're just going to go and look for a HPV test, and of course women can take that themselves by doing a swab and sending it off. And this is where the future probably lies. I have to admit, the focus at the moment, I'm involved with FIGO on that. And FIGO and the WHO and many of the organizations, all of these elements of self-testing should make life easier, we hope, should improve the screening. But as you can imagine, we'll call the Western, the high-income countries, the incidences of cervical cancer will continue to fall. But you can imagine how useful that might be in low, middle-income countries, where you don't need necessarily to have your cytology people, you just do your HPV testing, and then you need your colposcopy to be present there. However, vast amounts of money and effort is going in to try to vaccinate the young girls in those countries presently, with Rwanda being significantly the first country to really go for it, as they say, and they have an excellent vaccination program, which has hit 90% of the target population.
Fantastic. So when can we hope to see the output of the swabbing process coming out and the trials coming out, do you think?
I have no idea where the trials are at the moment. I mean, it is viable to do it, if you like, but I haven't got my finger on the pulse with regards to any trials that are ongoing. I haven't got the figures in my mind, but I know it's a viable option, definitely.
Thank you for that. Any other comments or any questions from anyone at all?
On any of the gynae cancers. It'll be outside the brief of this, by the way.
Bishmeen Jadoon, you've got a question, please ask.
Oh, hi. Thank you. Yes, hi, Sean.
Hi.
This is Bismeen. I'm a consultant at Royal Berkshire. I hope you remember me.
I do indeed. Yes,
Yes.
I saw the name.
Great. Great presentation. Thank you so much. Just one question I want to ask. So for the endocervical cancer, would you recommend doing PPIL for those women? Because you get normal smears for them. Yeah.
You can get normal smears. And I think really when it comes to the endocervical ones, the tendency is that unfortunately they will present where you can actually just get a little biopsy. I don't think there's any need looking for a PPIL. When the suspicion is high, you're probably, if going to get tissue, will either do it in the outpatients, and that's where you would use the colposcope to get your tissue, or you may decide it's safer just to bring the patient in and do an EUA and get biopsies that way. PPIL's never really been tested out for an endocervical tumor. It's usually direct visualization and taking of samples that occurs.
And would you get suspicious if you see sort of endometrial cells or endocervical cells in your smear test?
Yeah, they used to. Yeah, they will actually nowadays. They will make a mention of that, and I know on some cases they will say there is a concern because occasionally, of course, you're going to get an abnormal smear and it's an endometrial carcinoma. So in themselves, I found that at least what I've experienced anyway is that they will usually give you a hint that there is a concern of some other abnormality being present, and please check out the endometrial cavity as well.
Oh, great. Well, thank you. Thanks for that.
Thank you for that. That's really useful. Just coming to the end of today, I think there's a bit of discussion going on about rejection of referrals. Anne, do you want to just explain some of this? This would be quite useful.
Well, I've never seen a rule saying that you're not allowed to reject them, but what we do is I do some of the triaging, so do our gynae oncology team, our gynecology oncology team. And so, for instance, if they don't fulfill the criteria, which I have to say we've just heard very, very succinctly about. I mean, it was an excellent presentation. If they don't fill that criteria, then we write back and say you do not fill the criteria for referral to a 2-week rule clinic. And then I usually give some advice. I can see the patient has bleeding on HRT, which he's been on for the last year. She's on a no bleed preparation, change the formulation, add in extra progesterone. I do that sort of advice. Or as I've just had one yesterday, patient is seeking IVF treatment, is 38, has had a hysteroscopy, and they've seen a polyp, and that was referred on the 2-week rule because it was felt, the patient was told by the GP, well, it could be cancer, but we need to get you in quickly because you need your embryos in. So that would be an obvious one to reject, wouldn't it? So that's, I mean, I tend to err on the side of caution. If I'm not sure, then I just accept. But honestly, I think we would be overwhelmed. I mean, last week, the week before the strike, we changed virtually all our benign gynae into 2-week rule clinics. We were just overwhelmed. We're getting 30, 40 a day sometimes.
And it's going to get worse. It's going to get worse, I'm afraid. That's the thing, because I can just do out the figures for postmenopausal bleeding and endometrial cancer rates, and it's quite frightening. And they will keep going up.
Yeah,
it's
and
been
we've got
increasing.
The sonographer as well, who we can refer if they can't get a scan. It's patchy in our area. Some people can, some people can't. If it's clear we just need a scan, that's why they've sent it in under endometrial cancer. scan, endometrium's 2 or 3 millimeter, I just send that back, the result back to the GP and to the patient, saying your GP sent you in to screen for endometrial cancer. I'm pleased to report that your scan is normal, and I'm referring you back to the GP to take matters further.
That's a good system, that. Yeah, good system.
It does take a bit of legwork on my part and on the triagers, but it's worth it. It's worth its weight in gold. And of course, the GPs learn what we'll accept and what we won't. So, you know, in the nicest possible way. And we do give a bit of advice so they understand how actually they can manage. And we do always say at the end, if you have any further problems, do refer back. You know, we're not saying you can't give us a referral back if necessary.
That's really useful. Bismeen, you've got your hand up. Is that a new one or a legacy hand?
Sorry, that's a legacy hand. I'll put it down.
Okay, all right. I thought you're going to share your wisdom. That's what it was. Okay. Listen, it's been a really, really useful. Thank you for a fantastic presentation and very clear, Sean. Really helpful. And thanks for the interaction from everyone. Now, we've got a few reading and resources. The Red Whale, there's a very good handbook, Red Whale. So if you go on the Red Whale website, you'll see some fact sheets and some information there. I'm sorry, we forgot to put on here, Gateway C is a free resource available, which has been commissioned by Health Education England. They've got modules on gynae cancers, which are fantastic. Actually, I can't recommend it enough. Gateway C is a fantastic resource. They've got modules there. And for those people who GPs who go through appraisals, you'll get big brownie points, actually, if you do a Gateway C module. Very easy to do online. We're going to record this webinar. It's being recorded and it will be on our website, the Thames Valley Cancer Alliance website. If you have any comments or queries following this, please do get in touch with the Alliance. But we are organizing a few new lunch and learn events coming up. So on the 27th of April at lunchtime, it might be an hour, not 2 hours, maybe 2 hours as well. But the lunch and learn on the 27th of April is 2 hours. And this is for any health professional, and specifically the R's people. We're going to do some cancer training on cancer awareness and variety of cancer issues, but it is open to all. So please look out for that and join us and register for it. On the 25th of May, we've got one on prostate cancer. On the 8th of June, we're going to talk again about this fantastic guidance about FIT, with fecal immunochemical tests, give you a big update on it with all the new guidance that has come out. So we've got a few planned items for all of you. We hope you find this useful. But if you please could complete a survey and give us some feedback, you'll find the QR code there or link below here. Please complete this. It's only short, few questions. It really will help us to make sure we organize things. So please let us know if there's anything we ought to be doing anymore. Patients are increasingly demanding of us in primary care, with many having researched keywords to say trigger referrals. So that's one of the comments in the chat box, Sean. I think the internet has made a big difference to people. So Professor Google has a lot to answer for, but we as clinicians have to do what's right, don't we, Sean?
Yes, indeed. I've always warned people about, going onto Google isn't necessary, and they'll find things that referrals do in the United States which are entirely different, etc., etc. But I do empathize, I have to say, because that is tough. Somebody coming in and saying, "Here's my list," and it fits that. So yeah, challenging.
Yeah, it's also managing risk, isn't it? Really, you have to do what's right for the patient following your assessment, and that's where the sort of referral pathways are really important, aren't they? Really.
Indeed. Yes. Yeah.
Okay. Well, finally, guys.
Lots of demands. Yeah. Okay.
Sean, thank you so much again.
Not at
really
all.
Brilliant again, as always. And thank you all very much. Please look out for these new items coming up in the future, and please complete the sort of feedback survey. Thanks, Claire, for organizing today as well, everyone. And keep well. All the best.
Take care. Bye-bye.
Bye-bye. Bye.
If anyone wants the links to those upcoming sessions, just pop an email to the TVCA admin account.